Welcome everybody. I'd like to welcome everybody to our ViewMedi presentation tonight on the complex total knee, overcoming retained hardware and deformities with smart technology. And I'd like to thank Ortholine for helping us out with this presentation. So my name is Dave Mayman. I'm an orthopedic surgeon at the Hospital for Special Surgery here in New York City. I'm going to be giving a brief overview of Ortholine technology. And then we've got a few presentations that are going to be showing you how we use this technology in the case of deformities and hardware in both the femur and the tibia. So initially, I'm going to go through Ortholine, how the technology works, show a couple of videos on the technology for people that aren't familiar with the technology. So in terms of disclosures, I am a developer for Ortholine and hold stock options in the company. So Ortholine, what was the design rationale? So this was something that was designed close to a decade ago now. And basically what we did is we looked at large console navigation and said, okay, we know that this is accurate navigation, but a lot of people don't use it, and a lot of people don't use it because there are many barriers to use. So can we eliminate these barriers to use? Can we get rid of the capital equipment cost? Can we get rid of the learning curve? Can we get rid of additional time necessary in the operating room for navigation? And can we get rid of optical tracking with line of sight issues, pins and arrays in the bones, and multiple incisions that people don't want to make? So we came up with a device that basically looks like a standard tibial cutting guide for the tibia with a couple of extra bells and whistles. So you put the device on the leg. There's a spring that goes around the leg to hold it in place. There are two pins up on the top that hold it on the proximal tibia. And then there's a probe that goes on the ACL footprint, and you register the medial and lateral malleoli. And I'll show you a video of that in a second. You register the medial malleoli, you register the lateral malleoli. The computer calculates the center of the ankle. That way you've got the center of the knee and the center of the ankle, so you've got mechanical axis of the tibia. And then you adjust the alignment. In real time on the screen, you see posterior slope, you see varus valgus angulation compared to the mechanical axis of the tibia, so it doesn't really matter what's going on in between. It doesn't matter if you've got a zigzag deformity of your tibia, because you're looking at mechanical axis, and you can see that in real time. And if you want 3 degrees of slope, you can set 3 degrees of slope. If you want 0 slope, you can set 0 slope. If you want 7 degrees of slope, you can set 7 degrees of slope. And then in terms of depth of resection, we use a standard mechanical guide because standard mechanical guides are easy, and they've been just as accurate as any navigation guide that we've seen. So a video of the tibia here. This is real time. So this is me putting the device on the leg. Spring goes around the leg to hold it in place. There are two pins that go in to hold the guide in place on the proximal tibia. Now I know where the ACL footprint is. I look at the guide at the top, and it tells me the offset to the ACL footprint. So I set that offset on the bottom. I register the lateral malleolus. I come over to the medial malleolus with the probe. I hit a button to register on the medial side. And then right now in real time on that screen, I'm seeing posterior slope and varus valgus. I adjust the guide until I get to the numbers that I want. If I want neutral mechanical axis, I set it to 0. If I want to put my tibia in 1 or 2 degrees of varus in a varus knee, I can see 1 or 2 degrees of varus. I put my tibial cutting block in place, and then I put my depth guide in, and you'll see my depth gauge coming into position in a second here. And I can set that depth gauge just like any normal depth gauge at whatever height I want. And then I've got a navigated tibial cutting block. I'm now just pinning it in place. I've got a navigated tibial cutting block where I've set my varus valgus, I've set my slope, and I've set my depth of resection. Okay? That video was 1 minute and 31 seconds, and that was real time. So this doesn't take an extended amount of time like a lot of navigation systems may. Okay, so if we look at the femur, it's a similar technology, but there's a device that goes onto the distal femur. There's one pin that goes in place in the center of the knee. So this is your center point for your mechanical axis. There are two cross pins. These cross pins are just holding the device in place. So it's really just to stabilize the device. And then you get your accelerometers and your sensors in place. And now we have to register the center of the femoral head. So there's a maneuver that we use to register the center of the femoral head. And you'll see that right now. It's knee out to the side, then knee up and down. And that's rotating around the center of the femoral head. So that gives you your center position. So now I've got mechanical axis from the center of the knee to the center of the hip. And in real time, I'm seeing on my screen my flexion angle and my varus valgus angle. So again, if I want 3 degrees of flexion, I can set 3 degrees of flexion. If I want 5 degrees of flexion, I can set 5. Varus valgus, you have to remember, is mechanical axis alignment, not anatomic axis. So typically, we're aiming for 0. In a varus knee, I may put 1 degree of varus in that femur. Again, for depth of resection, we use a standard mechanical guide because mechanical guides work well. So we've got paddles that sit on the distal femur for depth of resection. I'm pinning my distal femoral cutting block, and then I remove the guide from the distal femur, and then all we have left in place is our distal femoral cutting block that's been navigated. So you can see here you've got your distal femoral cutting block. It's got multiple pinholes in it, so if you want to take 2 extra millimeters, you can, but you've got your navigated distal femoral cutting block. Pardon me. So that took under 2 minutes. So again, in terms of time, this isn't something that takes a lot of time in the operating room. It's easy and it's accurate. So here at HSS, we actually did a lot of work looking at the accuracy of this device. We did a study with multiple surgeons looking at accuracy on the tibia. We looked for results within 2 degrees of neutral mechanical axis. And what you can see, we randomized patients to standard mechanical guides or the KneeAlign with the tibia. And you can see in the conventional group, 70% were within 2 degrees, which is pretty standard if you look at the literature. And in the KneeAlign group, 96% were within 2 degrees of neutral. So this works. There's no question the technology works. Another study published shows 53 unilateral total knees, mean follow-up close to 2 years. Basically, the bottom line with this was the ortholine navigation system is accurate with less drawbacks than previous large-scale navigation systems. So that's been a brief overview of how the technology works. I'm going to pass this off to some of my colleagues here to show you some cases where this can be used in more complicated cases. This can be used in any primary case, but can also be used in complicated cases with deformity and with hardware. And that's probably some of the best uses of this technology because it's really hard to use standard mechanical guides for these cases. So thank you very much for your attention. I'm going to pass off the mic to Dr. Mangiapani, who's going to talk to us about using ortholine technology when there's hardware present in the knee.
Okay, so I very much want to thank Dr. Mayman for more or less passing along the mic. And he's truly correct where the KneeAlign technology is truly applicable to more complex cases, and that's probably one of the biggest things for me. I work at a small private practice hospital for the most part, and so where I would usually have to book cases for post-traumatic cases or retained hardware cases, would have to book very expensive kind of top-to-bottom implants where I'm probably spending more money up front on SPD costs and inventory costs. I'm saving money on intraoperative technology and saving that space and that setting. So I am a consultant for ortholine. So just quickly regarding my total knee technique, I use a measured resection technique that more or less matches the patient's anatomy. I was trained at Duke by Dr. Mike Bolognese and then subsequently by Dr. Aaron Hoffman out here in Salt Lake City, Utah. So our philosophy generally is to match the patient's anatomy. So, but still we will take the PCL, we'll end up using a cruciate retaining femur, and then our liner will be an ultra-congruent deep dish poly. So what that does is, at the same time it substitutes for the PCL, but at the same time allows you to use a bone-sparing operation in the primary knee setting by not having to make a box cut while still taking the PCL and still use the CR femur. We recently published a paper from our group called Less Valgus for the Varus Knee. At certain meetings, we've tabbed it as a gentleman's varus alignment. It's more or less an anatomic alignment that we've kind of coined that term where we dial in essentially probably 2.5 degrees of varus for varus knees on the tibial side. And then for valgus knees, I use a classic tibial resection. So I navigate all my femurs at this point. About 30% of my practice is cementless. My goal is to dial in about 3.5 degrees of flexion, which quantitatively I'm able to do that with KneeAlign, which helps me greatly. Varus valgus wise, I'm matching the patient's anatomy, and I perform an equal 10 millimeter resection per my measured resection training technique to account for asymmetric cartilage loss. And then selectively I'm navigating tibias. Really depends on the deformity, but for varus knees, I'm trying to dial in about 2 to 3 degrees of varus to ensure that there's no, what I call the medial potato chip. There's sort of, if you do a classic anatomic resection on the tibia, for a varus knee, what you have is a very thick lateral tibial wafer and then a very thin medial wafer. So if you're in the cementless knee business, that doesn't always translate into good fixation for a cementless knee construct. And so for a valgus knee, I'm dialing in a classic 90-degree resection, kind of what we call the center technique. On the tibias also from the sagittal plane, I'm putting on a 6-degree slope, which matches the cutting block of my system, which is slightly less anatomic. For a PCL sparing knee, I obviously take the PCL, so I take a little bit of slope out of that. And then, of course, looking for about an 8 to 10 millimeter resection from the high side on a varus knee. That's obviously the lateral side. I try to get every tibial resection and block and measure that entire tibial wafer on the medial and lateral side. What that does for me is it helps predict my poly thickness, and it probably shortens my case anywhere from 5 to 10 minutes. So this is a general look of what I have for that medial pin that Dr. Mayman had described. I'll draw attention to my my index finger on the sawbone. What I like to do is create enough space. This is a navigation from my distal cut on the femur side, where I try to put at least I have small hands, so at least one of my index finger breadths between the distal cutting block and the anterior surface. What that does is it accounts for significant deformity if there's massive osteophytes on the anterior side. I think one finger breadth from, again, my small hand can account for that for the most part. So that's what I was trying to highlight there. Again, you see the central drilling pin and then the fixation pins there. So this is what I go for on the distal femoral cut, and this is primarily for a cementless knee. Pretty much all my navigated knees at this point. So on the left side, what you'll find is a reading that's far an extension. What you may get once you dock these femoral cutting blocks. And then as you can see on the left side, I dial in through a simple screwdriver mechanism. Anywhere from 2.5 to 3.5 degrees of flexion is what I shoot for. You can see on the varus valgus side, similar to Dr. Mayman, I'm looking for a 0-0 mechanical axis, which is what I'm shooting for. So that's what we're working towards on that respect as well. So once you've docked your navigation technique, those are what I call the paddles. So the paddles allow you to measure for depth of resection. So for me, the thickness of my femoral implant is about 10 millimeters. So I try to take off 10 millimeters from the distal femoral cut if I can. And so what I'm shooting for, particularly with cementless knees, is an equal resection. So as Dr. Mayman said, we shoot for the mechanical axis of the hip center. So if you've nailed that, and there's actually a lot of wiggle room, I've actually asked the engineers how much you can deviate from that, because I sort of send that one in and then start putting the parts on. And I do that relatively quickly. And so once I get depth of resection, you can see in the picture on the left, that's what I'm shooting for. So if I get an image on the right where I say I'm airballing on the lateral side of the femur, I go ahead and I look at my preoperative x-ray and say, wow, does this femur anatomically have a lot more valgus dialed in, some varus on a varus knee? And so I make anatomic adjustments based on a nice sort of seesaw act between depth of resection and as well anatomic as well as mechanical alignment. And so I think when you're looking at cementless knees, and if you're a measured resection person, that takes into account. And so I've had incredible results even with massive deformities, and I'll show you that shortly. So going on the tibial side very quickly, again, excuse me, I apologize, we're on the femoral side here. And so you see what we have on the left-handed image is this femoral cutting block. I'll draw attention to your non-headed pins. So these are pins where you can, as Dr. Mayman has expressed, you can take your distal femoral cutting block and put that either 2 millimeters less than or 2 millimeters greater than your initial navigated femoral resection. So then I have another sagittal plane of how that works. So you can easily slide those off. And then as I move to the tibial side, again, I more or less follow Dr. Mayman's recommendations in terms of navigating. So I won't belabor those too much. But in my system, you can see on the far right, I move from, this is the middle image is what I get on a navigated sawbone, so about 3.5 degrees of varus, about 4.5 degrees of slope. My goal is to dial 6 degrees of slope into every tibia, and approximately between 2 and 3 degrees of varus for a varus knee. And so that is what I have settled in on in this particular sawbone. And then again, you can see on the sawbone demonstration, really from the coronal views and both sagittal views, you have more or less an equal resection, which is what I go for based on my philosophy for primary knee. So I'll be happy to describe this on how this works around more complex cases. Obviously, anybody can put and navigate a knee around a sawbone. So the first case that I'll describe is probably your classic total knee around hardware case. Someone who got a retrograde femoral nail and needs a total knee. This is an 81-year-old male who's had a cephalomedullary nail for a hip fracture. His past medical history is significant, mostly for peripheral vascular disease. He doesn't have any neurovascular deformities or history of myocardial infarction. Hence, he more or less for an 81-year-old, at least in North Carolina and Utah, has the standard gamut of comorbidities. His pre-op range of motion was lacking. I'll show you, he did have a near breach of the anterior cortex with that femoral nail and a broken distal interlocking screw. He's a very interesting person. He was a Vietnam vet. He's a lamb rancher at his baseline, lives in northern Utah. He shoots rifles competitively, and he's an avid game hunter. So we needed to get him back out into the wilderness as quickly as possible. So as you can see, he's got this pretty standard classic x-ray for an 81-year-old who needs a total knee. However, he has this distal femoral nail put in from a cephalomedullary fashion. His radius of curvature on that nail was not as robust, so it's a relatively straight nail. It's kind of tickling that anterior cortex there, right where if you're worried where you might notch, that might be a problem. Also, you can see he's subsided and broken his distal interlock screw, which has made his hardware a little bit more difficult to deal with. So, in the standard fashion, we dialed in 3.5 degrees of flexion of the femoral component to ensure that the anterior resection does not cause a stress riser amongst the femoral nail. And then, again, in the standard varus knee fashion, dialed in about 2 degrees of tibial resection, measuring approximately 8 millimeters, both medial and lateral. So this is our final x-ray of that case. We were very happy with how that turned out. As you can see on the lateral view on the right image, we bypassed that distal femoral aspect of the nail where there was question of breach of the anterior cortex. and have bypassed that nicely. And the thing that I'll draw your attention to is, while I didn't use a CR PS-sparing implant, I used a straight-up PS-stabilized implant on this case. However, these are primary parts done around a relatively complex knee, where I think in normal terms you'd use patient-specific instrumentation, preoperative cutting guides, where I was able to essentially open one box and do this case all intraoperatively without any extra imaging. So again, this patient is approximately 2 years out. His range of motion significantly improved. He continues to raise lamb on the ranch. He placed third in his local rifle shooting competition that was labeled as the Suns Out, Guns Out. It was a summer competition. I will be querying him for lamb later this fall for my Thanksgiving dinner. So, case number 2. So, somewhat interesting. This is more on the tibial side. This is a total knee following a tibial plateau malunion. This is a 67-year-old male who fell off his deck, quote unquote, after a few beers. I actually have a very soft space in my heart for this man. He's another Italian man who, unfortunately, despite just having some hypertension and being relatively healthy on the weight side, he is an alcohol enthusiast, and states when he came to me, he says he has not walked for about a year, and his leg is veering off to the side. So I was happy to take him on in clinic and look at his tibial deformity. So clearly at some point he had this left tibial plateau fracture fixed. It did not appear that his lateral defect was tamped up appropriately, and he had clearly continued to go on a post-traumatic arthritis. This is over a year later. So at this point, I chose to stage this young man just due to, he obviously had a long history of infection, and so there are other extraneous factors that went into staging him. However, in staging him, his deformity did get worse intra-articularly. You can see, as he said, his leg was veering off to the side, so he essentially had this quasi-malunion, questionable partial union, nevertheless this giant valgus deformity with a large lateral tibial defect. So the goal here, again, sticking to the goal of using primary parts, no top to bottom, 10 tray situation. I navigated the femur and the tibia. I used my classic tibial resection for a valgus knee. So that means center of the hip, center of the knee, center of the ankle joint. I did measure his depth of resection off the medial side given the deformity. I used rebar screws for the lateral aspect for tibial defect. And I did cement a 50-millimeter primary stem to bypass that defect. And so this is what we ended up getting. I used two 35-millimeter screws. I'll divert you to the kind of the lateral side where I'd like to think we got bicortical fixation. Looking back, I probably would have rather used 25-millimeter screws just for sleeping better. But more or less was incredibly happy with this navigated fit. Again, to the center technology. What you'll notice on the tibial side is that I kept this tibia relatively anatomic, so about a 90-degree cut, as opposed to our varus knee, where I try to dial in 2 to 3 degrees of valgus, or excuse me, varus, if I can, to match up the patient's anatomy. So I was incredibly happy with the way that case turned out. At 6 weeks, he actually had incredible motion. He actually surprised me quite a bit with how well he had done. You can even see on his on the image to your left where his socks had been a little bit constricted for the edema, just in conjunction with the fact that he had been non-weight bearing for over a year. But this young man had bounced back quite nicely and was incredibly happy with that case. Unfortunately, he was lost to follow-up for the subsequent years. I assume that he is back enthusiastically consuming alcohol, which is okay. So moving on to case 3. This is a conversion from patellofemoral joint arthroplasty to a total knee. This is a relatively younger patient. This is a cementless case. He had a partial patellofemoral joint replacement approximately 2 years ago. He states that it had never been right. This is a man who is 6'4", approximately 260, 270. He had served in the Navy in Bosnia and Herzegovina. This is a young man, relatively large male, who's been through some of the serious issues overseas and had got a partial knee replacement, perhaps a little prematurely. So to use this Arthrosurface implant, which didn't work too well, particularly at this young man's size. You can see he's got some medial-sided wear, particularly lacking a little bit on the lateral side. But at this point, his exam, he had hurt all over his knee. And you can see as we get to the patellofemoral view, a lot of bony contact there, and just not a greatly done patellofemoral joint replacement, depending on what your thoughts are on those. Probably a discussion for another talk. But nevertheless, I felt like he needed to be converted. So we went cementless. That was the goal on him, given his age and his bone quality. So for him, I generally use a thicker saw blade. For cementless cases, I use the 50F saw blade. That's slightly thicker than the 39F that you probably see on your normal cementless knees. And what that means is while that allows for less bend and rigidity, so you can kind of feather in some artistic qualities to your cuts through the 4-in-1 cutting block, certainly less room for error in the cementless situation. So that's specifically why I use that. You need a flush particular fit of your femoral component. I get fluoroscopic views despite being relatively younger. That's a pretty old school way of looking at it, but for cementless knees, I get a fluoroscopic view after every case. It takes less than 60 seconds, not a big deal. Further sort of feathers that you can think about when doing cementless knees. So one of the greatest things Aaron Hoffman ever taught me was that a cementless knee is an entirely different operation than a cemented knee. And these are some of the highlights that we try to talk about. So don't burn the bone. So I tend to irrigate these bones a little bit more. I have a lower threshold to take 2 more millimeters of bony resection, both on the tibial side and on the femoral side. So I try to take that into account preoperatively if I can. And then I do use what's called a slurry. This was written about in the 90s by Dr. Hoffman about taking your tibial wafer. I essentially use a patellar reamer and ream out. Another reason why getting a couple extra millimeters thick of a tibial resection, if you can help with that. We call it biological cement. So actually pretty good data to show that if you actually have bone graft in those porous ingrowth surfaces, that you get a stronger bond. And then lastly, I try to do a subvastus approach for every single one of these patients. If I'm doing a partial knee or particularly a cementless knee, again, sporty knee gets a sporty approach for the most part. If I could do it, this particular patient, too big and already had a medial parapatellar for his patellofemoral, ironically, but so a little too much scar to safely do a subvastus on him. So here's a little intraoperative photograph of his case. Can clearly see the wear, and if I can direct your attention to the patellar side, which you will see on the right side of the image, and then at the superomedial side of the patellofemoral joint over on the left side of the image, you'll see actually some metal corrosion over there simply from a PFJ implant. It was actually pretty wild, one of the first times I'd ever seen that. So as you can see, the fluoroscopic views in the standard fashion, we're able to do a nicely cemented knee. As I said, I dial in about 2 to 3 degrees of gentleman's varus into the tibial component, which you can see. Try to get a perfect AP and lateral in every case if I can, particularly for cementless, just to be a better judge of myself. And again, with cementless knees, I think placement and being accurate with your implants is everything. So quite honestly, even a post-traumatic situation, I would navigate every single cementless knee. I'm navigating every single cemented knee. But again, in these situations, it's very, very convenient and actually has saved me both money and time up front from a preoperative planning standpoint. So again, going back to the follow-up, he's about 1.5 years out. I probably forgot to mention that he is a large golf enthusiast who was unable to golf after this. A year after this operation, he's now playing 18 holes again. He's very happy from that standpoint. So, to really drive this home, I think the point of this panel and discussion is to say, how did smart technology really help me? So I'm a total joint surgeon out of Salt Lake City, Utah. He's fellowship trained, and so I I don't always think that a straightforward primary case warrants necessarily navigation. I think Dr. Mayman's data about how accurate you are is incredibly compelling, which has prompted me to start almost navigating all my cases. But to really highlight this situation, it's really so these complex hardware cases, there is no case now where I feel like I have to book a possible revision backup system. So every patient now with complex hardware cases gets primary implant. So you're saving money. You're not putting in constraint. I mean, for the long-term longevity and survivorship of the implant, you are being incredibly kind to your first operation, particularly for the patient. What I also like about smart technology, obviously, was highlighted in the first case, intramedullary jigs, so you can avoid things like tibial nails, femoral nails, all situations. I think it's my opinion that PSI are probably things of the past based on this, given the extra imaging that's involved. So in my second case, I think I highlighted that you can still navigate large tibial defects that are left by hardware failure. And so that was something that really changed the game for me. I was probably booking augments and constrained components prior to being able to use KneeAlign technology for this. Now I'm simply rebarring tibias, doing a good cement job, and bypassing a badly done tibial plateau fracture. And these patients do excellent. And then the last question is, it's like whether you can achieve precise cementless fixation if you're converting partial knee implant. So it's easy to do a cementless knee on somebody. You're just accurate. You can change your operation slightly to ensure that the patient gets a better operation. However, if you're converting someone, it's not uncommon as a joint surgeon, you are going to be in the situation where you're converting a partial knee replacement, whether it's a patellofemoral, whether it's a medial uni, lateral uni, you're converting those into total knee replacements. Those patients tend to be young sometimes, not always, but maybe great candidates for cementless fixation. So if anyone's looking at the trends and what's happening in terms of cementless technology, you'd be remiss if you weren't paying attention to that. And so very much trying to pay attention to that. And then last but not least, for me, as Dr. Mayman, I think, eloquently detailed in the first talk, this is an easy button. It doesn't take a significant amount of time. We'll discuss a little later. This is not something that took many cases for me to understand how to use and get my OR times back to how they normally are. In fact, I would argue in some cases they've decreased my OR times in terms of the money I'm spending up front on imaging and also planning. And so I think from that standpoint, knowing that as long as I have KneeAlign around for difficult cases, that's significantly helping me in the OR, making me more efficient, and then at the same time providing patients with implants that feel a little bit more natural because they're not constrained, and then not having to harbor my reps in my hospital by sterilizing unnecessary equipment. So with that, I'll close it out, and again pass the mic off to some very smart surgeons out in California who are dealing with some very difficult deformity cases, quite honestly, that had me hooing and hawing just at my computer here. So again, thank you again for the time, and to Ortholine and ViewMedi for having me here. And again, if there's anything I can provide, it would be that smart technology makes complex cases less complex. No doubt about it. Thank you.
Well, thank you for inviting me in this discussion. I am Mauro Giordani, a clinical professor of orthopedics at the University of California. I think that speaking about complex cases, retained metal, oftentimes we have the discussion on whether to keep or not keep the metal that is in the patient and may impede our surgery for total joint arthroplasty. So the discussion often comes up to remove prior to implantation as a separate procedure. I think we think a lot about that, especially if there's a history of infection. I would probably go forward and take the implants out before implanting a total knee arthroplasty. and other times where there's no history of implant complication or infection, if they are grossly not impairing the implantation and possibly having the implants in the field where we're doing the surgery, many times the implants that impede the implantation can be removed very easily from the field of view by directly doing a knee arthroplasty. So our guidelines are very, very clear. It's very well delineated in the literature that extra-articular deformities greater than 20 degrees in the femur or greater than 30 degrees in the tibia usually require correction via osteotomy and internal fixation prior to implanting a total knee arthroplasty. And in the sagittal plane, if it's greater than 20 degrees. If you are going to do a total knee arthroplasty and it compromises the ligaments in any way, that being the arthroplasty or correction inside the joint with resection and the collateral ligaments are damaged, or you think they're going to be damaged, you should probably do a corrective osteotomy before you do the total knee arthroplasty. And in many of these cases, even so we do use special implants, you should always have a backup implant that should be available, and that would include, in our situation, a hinge. My first patient I would love to present is a 72-year-old female with bilateral knee osteoarthritis and severe valgus deformities who is 2 years status post bilateral bisphosphonate fractures treated with IM nails. On top of the fracture, she also had a long-standing deformity of valgus in both of her knees. She had no problems with healing of bisphosphonate fractures after the nails were placed, and she complained of left greater than right knee pain. She was scheduled for total knee arthroplasty on the left side, and postoperatively she was very, very happy. And you can see, using the KneeAlign ortholine instrumentation and guidance, we were able to put in a pretty anatomic knee. And 6 months later, we actually did her contralateral knee as she was so happy with her first one that she had matching pairs. These were very straightforward implantations, and the great thing about it now is that she is 3 years post-op and is very, very happy. The second patient I'd like to present is a patient with unilateral severe varus and the contralateral, what I would call mild varus deformity. Unable to work, he's a truck driver, and his right knee really, really bothers him. Again, this kind of deformity, I think many times, in some cases can be very, very straightforward, but with a lot of ligamentous laxity, it's presented in this particular case. KneeAlign helped us tremendously, and you can see we implanted a knee with a very, very good result. This patient too has or had a contralateral knee done 3 months after his contralateral side, also using the ortholine instrumentation. And then our last two patients I would like to present are what would you do in this particular instance? This is a patient who had multiple trauma, had open reduction with internal fixation, fortunately with no infection. And this is a patient that, of course, we will schedule for an ortholine implantation. Very straightforward. And then this other gentleman here I'd like to present is a 80-year-old gentleman with unilateral knee pain who has had this deformity now since the age of 16. And he started having pain about 10 years ago, and his basic goal is to be able to ride his bike and walk around the block. He currently uses aids for ambulation, and this patient is now scheduled for surgery next week. Again, you can see the standing film here creates a pretty significant deformity. Most of this is intra-articular, and I think we can take care of it with ortholine instrumentation that will help us realign him. In any case, I'd like to just reiterate the necessity for using our guidelines for when and when not to do osteotomies or corrective osteotomies, and those are very well delineated, and just as a reminder to all of those people that are doing this kind of surgery. And I think I'll end there. Thank you.
My name is John Meehan. I'm a professor at UC Davis Health. Dr. Giordani is my colleague, friend, and partner in joint replacement. And I actually owe my use of ortholine to him because he started a year before me, and we share a fellow, and the fellow convinced me to give it a try based on Dr. Giordani's results. This first slide is something that kind of is a hot topic in Sacramento, but I personally feel alignment matters long term. And as you can see, the left knee was placed in slide varus compared to the right knee, and this was an 8-year follow-up, and that left knee was going to require revision for that tibia, which had settled medially and was obviously loose. This was a patient that came to me, probably patient number 10 or 11 for ortholine, and it was a leap of faith on the femur. I started using ortholine first on the tibia because it was very similar to what I was used to in terms of an extramedullary guide. But prior to ortholine, this was a patient I probably would have considered patient-specific instrumentation cutting blocks. But I had started to gain confidence that ortholine was giving me the numbers and the accurate cuts that the studies have confirmed. And so for me, it was taking a little bit of a leap of faith because I think it was only my second or third femur. And what impressed me the most was the sagittal view. And I think that's what's impressed me the most about ortholine in my femurs and my tibias is really how accurate it is in the sagittal view. Because that's the one view, especially on some deformities, and especially on the tibia, that I was making mistakes on, being an extramedullary guide person. But this was 2-year follow-up, and this person was doing quite well. I'm also a fan of simultaneous bilateral knee replacements in the select patients who are candidates, and this was a Dan Barry article, but what it shows is that 22% of people every year either undergo simultaneous bilateral or contralateral knees within 1 year. So there's a large patient group out there that could potentially benefit from simultaneous bilateral knee replacements. And in my practice, certainly this is ideal for not instrumenting either the femur or the tibia, especially if you're considering doing simultaneous bilateral knee replacements. This is just an example of someone not real bad deformity, but underwent simultaneous bilateral knee replacements, and I'm really a fan of the ortholine in this scenario. I like to throw this up because this was a gentleman who has an underlying diagnosis of COPD, but also felt to be secondary to this cryptogenic organizing pneumonia, which I must be honest, I had never heard of prior to doing his knee replacement. But this was his chest x-ray after he was readmitted on postoperative day number 10. And the treatment of this is high-dose steroids, which you can imagine, having just done a knee replacement on, made me quite nervous. This is a transesophageal echo video of what happens to the heart after you release the tourniquet. And if you wait a few seconds, you see all these shadows. And we know these in the past have been biopsied, and there's a lot of stuff going through the heart: bone, cement, air, fat, blood. And certainly, to me, it makes sense if we could minimize that. It would be a benefit to the patient's overall recovery. Again, this is a sagittal view, and this is really where I have found the ortholine to be useful and beneficial in its accuracy. On the left, you see an 18-degree posterior slope on that tibia, and I typically dial in 2 to 3 degrees based on my ortholine device, and you can see it gave me exactly what I wanted. And I can tell you that this, to me, has been the biggest plus and the biggest pleasant surprise is the accuracy. We all know the varus valgus, how accurate it is, but the sagittal view, it is extremely accurate as well. Just to throw in one more deformity case, this was an 80-plus-year-old woman who came in to my practice, non-ambulatory for the past couple of months due to this lateral tibial plateau erosion / fracture, and really had hinge available, had other options available, but with the ortholine device was able to properly align her and properly balance her, really without anything but primary implants. So it's been a nice addition to my practice. I can tell you in 20 years, I've only really changed 2 major things about my technical approach to knee replacements. One is I went to a posterior stabilized implant because in my hands it was better outcomes, and then 2, the ortholine device, because it has given me a more accurate cuts, which I do think translate into less soft tissue balancing, less bleeding into the knee joint from a large intramedullary hole, potentially less embolic phenomena into the heart, and all of that I think translates into improved recovery. So I use it in all my cases now, and consistent with Dr. Mayman, it's about 2 to 3 minutes to set it up and accurately perform it, but it's well worth the time. Thank you.
Great. Thank you very much, guys. We have 5 to 10 minutes just to go over a little bit of a discussion here. So those are great cases, very interesting points that each of you were bringing up. I just want to run through a couple of questions and get answers from each of you, and feel free to pose your own questions here. But first of all, I'd just like to ask each of you, what do you think the learning curve was? How many cases did you have to do before you were comfortable using the technology?
I can go first. For me, it was about probably 5 to 10. I mean, particularly on the knee side. I'm glad Dr. Meehan brought up the sagittal deformity accuracy, because that was one of the things that gave me great confidence in doing more cementless cases. As I said, for all my cementless cases, I'll do, it's very antiquated, but a little post-op fluoro. It's already in the room, and so it's very easy for me to do. And starting out, obviously, judging by the screens, I'm one of the younger guys around, but in adopting KneeAlign and getting those fluoro cases after, to Dr. Meehan's point, for cementless knees, the sagittal alignment has been so accurate that I've been very, very comfortable applying those even to post-traumatic cases, conversion from uni cases. So, and that has only taken me about 5 to 10 cases to get down to my kind of normal tourniquet time that I'm used to without KneeAlign.
Dr. Meehan, what do you think your learning curve was? Dr. Meehan, what do you think your learning curve was?
It was about 10 cases, and I started slow. I'm a little bit cynical, so I started first on the tibia because it was similar to using an extramedullary guide that I was comfortable using, and then I saw how accurate it was, so after somewhere between 5 and 10 cases, started using it on the femur as well.
Yeah, I think that's a pretty common scenario. People start using it on the tibia because it seems easy on the tibia. It takes just a couple of minutes to do it on the tibia. And then people get interested and they say, well, this has been really accurate on the tibia. Let me try it on the femur. And I think that maneuver to register the center of the hip is a little bit more difficult than any of the registration on the tibia. But it's kind of like riding a bike. You try it a few times. it doesn't work the first few times you do it, and then all of a sudden you figure it out, and then once you've done it once, every time it works. Dr. Giordani, how long do you think the learning curve was for you?
Fortunately, it was very, very small. I was introduced to the KneeAlign ortholine system first as a model and then with a cadaver, and used it a couple of times on a cadaver, and I saw it work there, and that was very, very easy. Maybe 1 or 2 cases, real time, in real surgery. It was very, very simple, straightforward, and I was convinced from the very, very beginning. But I will say all the studies that were done, that were published, I did read those thoroughly, and I was very, very confident that this was going to work. So I jumped in with both feet and was very, very happy.
So I think that's one of the important points to make is many people have tried navigation in the past, and they've had it in their operating room for 1 or 2 cases, and it's been a struggle, and the pins didn't go in right, the array, you couldn't see the arrays, something went wrong with the computer, and very quickly people gave up on it. And what I've seen with this is people try it once or twice, and they say, hey, that was pretty easy, that worked. And there are very few surgeons that try it and then say, no, I don't want to use it again, which traditionally with navigation, that's what's happened all the time. It's been accurate. We've had navigation systems around for over 15 years now, and people just try them, and they get frustrated and they give them up. And this seems like a technology that once people try it, they continue to use it. And it was interesting to hear Dr. Meehan talk about how he used it because you used it because you saw your partner use it and said, hey, that works pretty well. I'm going to give it a try.
Oh, okay. I was just going to say, one thing that has impressed me is the user interface. The software is so good, it doesn't let you go to the next step unless you've done everything correctly. And so it is very surgeon-friendly.
Yeah, and I would piggyback off of that and agree in saying that everything that your screen tells you on the handheld device is, it's very prompted. Like the directions are very clear. There's not a rep in the room like having to get you to the next step in order for you to move on with your case. So at the end of the day, despite your navigating, you're still kind of the quarterback of the operation, which I feel like sometimes with other navigation systems, like you lose that sort of quarterback control. And going back to the maneuver, I actually started on the femoral side because I wanted to get my, to Dr. Meehan's point, my sagittal alignment correct on cementless knees. And so I actually started on the femoral side. So we worked with the maneuver, and you can have some fun with it, make it a competitive thing, and see who can do the biggest patient with the maneuver, who can do it the fastest, et cetera, or less amount of time. But now to Dr. Mayman's point, once you get kind of the dance down, it's something that's just a part of your OR flow, and then like I said, between 5 and 10 cases was back down to my normal total knee times, which I'd like to be pretty critical of myself and like to think that I'm pretty efficient in the private practice setting.
I would just like to say that I have tried over the last 20 years all aspects of navigation. Did not use them on all my cases because it was onerous as far as time set up, then customized blocks, etc. Also cost effectiveness, trays, all that's required for the setup to do the procedure itself. And again, once I tried this, it was so simple, straightforward, surgeon-friendly that I couldn't go back to using any of those other devices that I'd used previously. It really made it much easier to do the surgery if you had to use some type of navigation system. It's so easy for me that I always use the system now for my primaries, and sometimes I use it even for my revisions, where I think that having minimal destruction of bone to do my revisions, I'll I'll use a KneeAlign to help me make my cuts.
So I would agree. I think that's one of the beauties of this system is that whenever you feel like you quote unquote like need to navigate, you can open up KneeAlign. I probably do this more on the hip side than the knee side, but doing like real-time intra-revision, getting, again, to Dr. Meehan's point, sagittal alignment. One of the cases that I omitted from this talk, it was not a total knee around a hardware case, but it was a revision knee around a hardware, or where hardware needed to be done. I had a flexed femur where I had to put in a retrograde nail, and I couldn't get the nail through the flexed femur because the roof of the notch was kind of covered and it was not accessible. So it was a primary system, and so I had to make the decision as to whether to bail, or I actually had these on backup, admittedly, but bail to constrained implants or just pop off a femur, do a retrograde nail, and like take the flex out of the femur and just put in like another revision, like revise the femur in an isolated fashion. And I did that, and we were able to measure it. We had a femur that was flexed about 7 degrees, and we measured it. And then I took literally 5 to 6 degrees out of the flex, was able to measure that. So I think even in the revision setting, you're talking about quantifiable numbers. I probably use it the most in retroverted cups for isolated cup revision and making that decision. But to your point, I think there's excellent utility in the kind of that no other navigation can offer, in the kind of on-the-fly decision-making that you can do with KneeAlign or HipAlign. I can tell you with other systems, like if you're trying to make those changes, you have to like redo the entire plan, which I like, oh, hey, I'm just wondering where this is at, dock it, measure it, and then make a quantitative scientific decision. I think that's, to Dr. Mayman's point, it gives you that extra like confidence in numbers, so to speak.
All right, so we've only got a couple minutes left here, so just in 10 to 15 seconds each, if each of you could tell me what is the number one reason that you use ortholine. If you just had to pick one thing and say, this is why I use it, this is the best part of it, what would each of you say is the number one reason you use it? So Dr. Giordani, why don't we start with you?
Ease of reproducibility, number one reason.
All right, Dr. Meehan?
It's accurate. It is very accurate.
And Dr. Mangiapani?
And going away from levels of constraint on backup in difficult cases. The long-winded answer.
No, great. So I think with that, we're running out of time. So I would like to thank the three of you for joining me tonight. I'd like to thank Ortholine for sponsoring this. And I'd like to thank ViewMedi for giving us the opportunity to present these cases and this use case for what I think is a simple, straightforward, and accurate navigation system.
Thank you so much, guys. Great discussion. I appreciate it. It was fun.